Good afternoon, everybody. Thank you so much for joining us this afternoon for today's second virtual roundtable. My name is Tamara Ortiz Perez, and I'm a breast imager at Baylor College of Medicine. I would like to start by welcoming the attendees and physicians from Latin America, Middle East, and the United States. As part of our mission to promote medical knowledge through the educational programs, the International Center at Baylor St. Luke's, in collaboration with Baylor College of Medicine, is honored to host this second international virtual roundtable to our network of physicians, medical societies, and the international medical community. Today's topic is, what do I do in the axilla after neoadjuvant therapy? A multidisciplinary approach. As part of today's programs, first we will have this excellent presentation from Dr. Alistair Thompson. Throughout the presentation, please feel free to submit questions via the chat box. After the lecture, we will open the virtual roundtable with questions and comments from our panelists, followed by questions and comments from the audience. Before introducing our fantastic speaker for today, I would like to welcome our panelists who are all from Latin America and will be joining us after the presentation with their opinions and questions. Let's welcome Dr. Hernan Lupera from Quito, Ecuador. Dr. Lupera is head of the Hematology Oncology Service and former head of the International Medicine Department of the Quito Metropolitan Hospital. Dr. Lupera is a member of multiple important international scientific societies and an editorial member of the eCancer Journal, as well as author of more than 30 scientific articles and book chapters. Next, we have Dr. Mauricio León from Lima, Peru. Dr. León is the medical director of the Cancer Detection Center in Lima, Peru. He is surgical oncologist subspecialized in breast, soft tissue, and skin tumors. He is the chief of the breast unit at Clínica Ricardo Palma and a staff member at Oncosalud. Dr. León is a health professional with more than 15 years of experience in the field of Peruvian oncology. Last but not least, we have Dr. Nereida Esparza from Mexico City, Mexico. Dr. Esparza is a surgical oncologist and breast cancer specialist in the surgical team of the breast cancer department at the National Cancer Institute in Mexico City. She is a member of the Society of Surgical Oncology, the Mexican Society of Oncology, and the Mexican Mastology Society. She is also a part of their scientific committee. In addition, she is part of the National Consensus of Guidelines for the Diagnosis and Treatment of Breast Cancer. Thank you, doctors, for joining us. We look forward to the discussion. Now it is my pleasure to introduce our speaker for tonight, Dr. Alistair Thompson. Dr. Thompson, getting your bio ready. I apologize I had it ready and it disappeared on me. My apologies.
Well, you could just introduce me as one of your colleagues and how much we enjoy.
Dr. Thompson is one of our wonderful breast surgical oncologists at Baylor College of Medicine. Dr. Thompson joined us from MD Anderson Cancer Center, as he likes to say, the other cancer center in the city of Houston. He trained in Scotland, and he's a wonderful asset to our team. Dr. Thompson provides many years of experience. He's a clinician scientist with multiple accolades behind his name, and it is a pleasure to have him work with us and be the speaker for today's roundtable. I would like to welcome Dr. Thompson and thank him for his participation today. I'm sure this is going to be a wonderful presentation. Thank you so much, Dr. Thompson.
And thank you, Tamara, for introducing both myself and the three amazing people from elsewhere who are also on this great opportunity to share information. So I'm going to share my screen, I hope successfully. We'll see in a moment. And what I would like to do is share with you some thoughts on what do I do in the axilla after neoadjuvant therapy, and demonstrate to you how important other disciplines beyond surgical oncology are, particularly your own specialty, Tamara, imaging, and pathology in getting it right for our patients. So let me see if I can move this down. There we go. What I would like to do in the next 20 minutes or so is first of all, as I've said already, demonstrate that there's lots of disciplines involved in this. I'll, in passing, mention what you all know, just how impactful neoadjuvant therapy has been on what we do in the breast. Spend most of the time talking about what we have done, what we can do, and then go on to say, what will we do in terms of managing the axillary lymph nodes? And I hope at the end of this 20 minutes or so, there'll be lots of opportunities to critique what I've said, the chances to ask questions, and maybe from our other panelists also to get some answers. So I work as part of a large team here in the medical center in Texas. You're going to hear from myself and Tamara today, but 2 weeks ago, you heard from two other team members, Carla Sepulveda in imaging, and Matthew Ellis, our medical oncology translational lead. I wanted to point out early in today's discussions that in 2 weeks' time, Marko Maricevic, who's one of our esteemed plastic surgeons, originally from South America, now here in Houston, is going to be giving the next talk. So, what about the impact of neoadjuvant therapy on breast surgery? Well, you can see in the top half of this screen that we have a patient who on ultrasound here has got a cancer, also evidence on MRI, more difficult to see on mammography. And after neoadjuvant therapy, which as you can see was for HER2 positive disease, you can see that the disease was much smaller. And we were able, on the top right-hand side of the screen, to do a lumpectomy wire-guided and preserve the breast with a lumpectomy. And in fact, we now know that both for HER2 positive disease and for triple negative breast cancer, some of the treatments our medical oncology colleagues offer are so powerful that we can completely get rid of and have a pathological complete response for some cancers. Maybe not so good for ER positive disease. 6 to 16% of cancers after neoadjuvant therapy disappear in the breast. Half of all HER2 positive cancers and more with some of the modern therapies, and about 4% of triple negative breast cancers. So that's been the impact that we're all aware of on the primary, on the breast cancer site. What about in the axillary lymph nodes? Well, if we go back over the last 20 years, we've long known that there are patients who with neoadjuvant therapy will go from node positive to node negative, perhaps as many as 40% of our patients. Depending on how we look in the axilla, with sentinel node identification, we can probably pick up about 90% of the positive node. But there is a problem with false negatives, and that's highlighted there, and I will come back to that in a moment. The problem that we share with our imaging colleagues, though, is that historically ultrasound or MRI or PET-CT has not been as sensitive as we would wish at trying to pick up what's going on in the axilla. And as I'll come to in a moment, the technique we use, the number of nodes, what sort of things we do like frozen section all make a bit of a difference. But I guess what we're trying to avoid, as you'll see on that diagram on the far right-hand side, if we're removing the axillary level 1, level 2, and even level 3 nodes, that purple-pink triangle, we can give the patient substantial morbidity, particularly if radiotherapy is then administered after the surgery. So there's a lot to think about here. Now, many people over the years have tried to address this problem. I wanted to highlight two trials to you. The first is the Sentina trial conducted by the German group a number of years ago. And they really had quite a complicated trial design, which I'm not going to bore you with all the details. But what they did demonstrate, as the blue line in the middle there shows, is that about 2/3 of patients went from positive to negative, at least on sentinel node biopsy. However, they still found that if the patient had originally been clinically N1 after the neoadjuvant chemotherapy, their sentinel lymph node biopsy detection rate wasn't great. It was still around about the 80% mark, and their false negative rate was still too high at 14.2%. And in the discussions of this Sentina trial, and also in the trial I'm going to show you in a moment, Chip Cody, who's a very eminent surgeon up at Memorial Sloan Kettering in New York, came to the conclusion, which I think many of us have subscribed to, as you can see in blue at the bottom in that bullet point, that if you're going to do sentinel lymph node biopsy, you should do it only once. You should probably do it after the neoadjuvant chemotherapy, and the technique you use, he was advocating for a dual technique of blue dye and technetium colloid, and the number of nodes you remove, he was suggesting you should take at least 3 sentinel lymph nodes, really matters if you're going to assess the axilla properly. Now, the other trial that many of you know very well is an American trial. I call it the Z1071 trial. The Americans tell me I'm pronouncing things. It should be the Z1071 trial, whichever it is. The key thing about this trial is that it showed, as you can see in the middle of this screen, that the false negative rate was really too high. The false negative rate at 12.5% was really not what was being hoped for. They were also able to say that the biological subtype, whether it was hormone receptor positive versus HER2 positive or triple negative breast cancer, as you can see bottom left there, that also made a bit of a difference, and quite a bit of a difference, to whether the patients gained a pathological complete response, including in the axilla. And so Judy Bowie, my countrywoman or countryman from the United Kingdom who led this trial in the United States, came to the conclusion that given the false negative rate of more than 10%, this really wasn't an approach that by itself was going to work. And so we needed to think a little bit differently. And so if I'm to summarize what the evidence had been about 5 to 10 years ago, the 8 to 14% false negative rate for patients who'd originally been node positive and were thought to be node negative, but the sentinel lymph node biopsy just wasn't working in 1 in 10, 1 in 8 patients. That was considered really not acceptable. And then a meta-analysis of 19 different studies, 3,398 patients, a pooled analysis, really confirmed that the false negative rate in that meta-analysis of 13% was too high. And so emerging on top of that data, there were 1 or 2 institutional series. I'm mentioning one here, which my colleagues at MD Anderson did, where they demonstrated that in 116 patients who had originally been node negative on ultrasound, on biopsy, they all stayed node negative. But amongst those who'd originally been node positive, if the patients converted to pathological complete response in the breast, then many of them, 9 out of 10, 89.6%, also converted to node negative, really driving the need to work out how can we assess the axilla more effectively. So along comes a new technique, the targeted axillary dissection. And as many of you are now familiar with, this requires a clip to identify the original positive node when the node has been identified prior to neoadjuvant chemotherapy, and then to give us as surgeons the opportunity to identify that node by either using a wire for localization, an iodine seed, radiolabeled iodine seed, something called a Savvy Scout, or a mag seed made of ferrous metal. And during the time of a sentinel lymph node biopsy, to include that identified clipped node, as well as the sentinel lymph nodes, if the clipped node isn't actually a sentinel lymph node. And you can read much more about this approach in Beth Mittendorf's really quite nice paper from 6 years ago. Beth was a colleague across the road in the other cancer center and is now at Dana-Farber Cancer Institute. So I was trained how to do this technique by Abigail Caudle, formidable lady surgeon who showed me how to do this. and guided me through the initial stages of me being uncertain as to whether it would work well or not, and it does work very well. And she had demonstrated, as you can see from these publications, that in her hands, that a sentinel lymph node biopsy alone, as you've already seen, 10% of the time it was false negative. If you went for the clip node alone, still 4% of the time, you would find additional positive nodes in the axilla when you went on to do the axilla lymph node dissection. And there was some concordance between the sentinel lymph nodes and the clip nodes, but 1 in 4 times, 23% of the time, the clip node was not one of the sentinel lymph nodes. So you really needed to go looking for the clip node as well as doing the sentinel lymph node biopsy. And if you combined those two techniques, sentinel lymph node biopsy plus retrieving the clip node, what she and her colleagues were able to demonstrate that 98% of the time, you were able to assess the axilla properly. And in only 2% of patients, 1 in 50 patients, did you get a false negative compared to axilla lymph node dissection. And you can see here at the bottom left, that little node that's visible on the original ultrasound, having a little marker placed prior to neoadjuvant chemotherapy. And then after neoadjuvant therapy, a seed has been put into it. And then across here on the right-hand side, a kind of confirmatory mammogram demonstrating both the little clip and the seed. And then below that, the node and some surrounding tissue being removed. Can everyone do this? Well, this is data from the Mayo, which they bravely, I think, published in 2017. The first 25 patients that they tried this technique with, they found that 18 of the patients, yes, they could use ultrasound to guide them to put the iodine seed in place. They needed CT scanning to place the seed in a further 2 patients. But in 5 of the 25 patients, 1 in 5 patients, they could not identify the pre-neoadjuvantly clipped node. So I think that pointed out to myself and others that it's not the surgeon that's the key person here. It's the imaging team that are absolutely critical to making this technique work. And so what's been my own personal experience, both at the other cancer center and since I moved across here to Baylor College of Medicine? Well, you can see here some of the problems I've encountered in about 75 of these targeted axillary lymph nodes. I've used different techniques depending on the institution, the iodine 125 seed, the MAG seed, and also the Savvy Scout. Show examples of those in a moment. Sometimes it can be tough for the imagers post-neoadjuvant therapy to identify and find a node. And I was fortunate that I could actually palpate quite a fibrosed sclerotic node, which I think had been hiding the little clip that had been placed into it, and was able to confirm at the time of surgery that I'd got the correct node there. Sometimes the seed is not placed in the node. I've found that in both the centers I've worked, that the imaging teams are fabulous, and they will say, look, the seed isn't in the node, it's 5 millimeters away, but that is more than enough to guide me to the right place. False negatives, well, even senior pathologists looking in the heat of the moment, or maybe it should be the cold of the moment, at a frozen section node, they sometimes don't get it quite right. And I've been quite surprised that a false positive is also possible, that the histiocytes that are present in a lymph node, even though there may be no tumor, can suggest that that node is positive. And the first time that happened, very senior pathologist, she said to me, this is tumor. So I went on and cleared the axillary contents to a level 2 axillary lymph node dissection, and the final pathology came back negative. The second time this happened, with a different very senior pathologist looking down the microscope, because I went round the corner to have a look, and we asked the question of each other, could this simply be tissue histiocytes? And he said, yes, it probably is. I don't think these are tumor cells. So I did not clear the axilla, and actually there were no tumor cells at all on the formalin-fixed paraffin-embedded final pathology. And then the final trap in all this is that a lot of the published data, a lot of the personal experiences many of us are having are that we tend not to apply targeted axillary dissection if 4 or more nodes have been involved initially. Now, I think that's probably the safe thing to be doing, but in the last 2 weeks, I've had 2 women, 1 HER2 positive, 1 triple negative, who had 8 and 9 nodes respectively. I didn't try to do targeted axillary dissection, and both of those have come back with 20 or more negative lymph nodes, lots of scarring in the nodes, but not a tumor cell to be seen at all. So there are things that we still have to learn, or I still have to learn, for targeted axillary dissection. But I wanted to make the point on this slide again that the imaging people are really important, but also our pathology colleagues. The interactions at the time of surgery and subsequently with pathology are very, very important. This is a team sport, and we need good team players from each discipline. Okay, so what I've been saying so far is just reminding ourselves about the pathway for neoadjuvant therapy. As you'll see from the 3rd bullet point there, I very much believe that whether it's breast conservation or mastectomy or even bilateral mastectomy, that should be driven as a patient preference. And you can see there 1 or 2 of the points that I'm going to come back to in a moment in terms of what sort of axillary surgery do we do, particularly if originally node negative, and axillary surgery for the originally node positive, still node positive. So before I finish, I wanted to maybe think about 3 or 4 future directions that I see this field going in. The first is to really question which technique should we be using for sentinel node biopsy. You can see that beautiful example top right. I wish every single blue and technetium labeled sentinel node looked exactly like that. And you will probably all be laughing to yourselves saying they don't usually look like that. There's also the question that blue dye is readily available, whichever blue dye you choose to use. But in many places, the technetium 99 radiolabeled colloid is either not available or is so expensive that it's not really practical to use. Is blue dye alone going to be what we can use here? I've toyed with fluorescent agents, indocyanine green, not really had a great success with those. And I'm beginning to make use of magtrace, the iron oxide, that little dark red dot with the dextran coating, the little white hemisphere next to it, which comes as a 2 ml dye that you inject immediately before you start the surgery. And within 20 minutes, it's gone, as you can see on the right-hand side there, to form a little brownish blob locating the lymph node. And you can see it and you can detect it with a detector. I think the magtrace has a number of advantages. Certainly in Houston, it's a lot cheaper than the colloid and actually cheaper than the blue dye we've been using. And it's quite practical, very safe, and in other settings has been demonstrated to be just as effective as the dual blue dye and colloid. So maybe things we should be thinking about for the future. What about how to localize the nodes? Now, these are not lymph nodes. You can see that, but I thought it would be a good example to show top right, good old-fashioned wire localization. It works in lymph nodes as well. Bottom right, using the iodine 125 seeds. They're good, but all the problems that I've experienced in the UK and in North America of using radioactive anything are typified by trying to use these seeds. And then top left, you can see the mag seed, the little metal seed, which I've actually found very straightforward, very easy to use. It needs a different detector to the iodine 125, but it's pretty straightforward to find. The downside to trying to detect that is you can't have metal instruments close by. You either have to use your fingers to retract, to put the probe in, or plastic instruments. And then bottom left, the Savvy Scout radio reflector, again, a very nice technology, but problems with that sometimes when you get the diathermy, the bovie, too close to the Savvy Scout, it does inactivate it, albeit temporarily. So different techniques. What are the trials that are going on that are going to maybe change what we do as surgeons in the axilla? Well, I was going to mention 3 to you, 2 of them which are ongoing, nearing completion in the US, and then a third trial which is just starting up in Europe. There are other trials, I know, but the ones I think we need to be mindful of are, first of all, this NRG, NSABP, RTOG trial, which is really trying to answer the question, is radiotherapy added on to whatever surgery we've done? Is that a good thing to do in terms of reducing disease recurrence, invasive disease recurrence? And built into that is obviously the question of side effects and lymphedema that you can generate by that combination of axillary lymph node dissection and radiotherapy. And then the second trial labeled here, the Alliance trial, which is saying that if you do end up having some positive nodes in that axilla after your neoadjuvant chemotherapy, is axillary radiation good enough, or do you actually need to do surgery and give axillary node radiation? And I don't know what the answers are to these 2 trials. I don't think anyone does, but they're going to give us some information probably in about 2 to 3 years' time, which may inform what we do. In a longer time frame, there's this British trial, which is just about to start up, which is saying, even if you have something in the axilla, do you need any additional treatment? Do you need any axillary lymph node dissection or axillary radiotherapy? Possible that you may not. And the primary endpoints for that trial, as you can see, include lymphedema, which I think is a very important patient-reported outcome. But these 3 trials and others are really trying to answer the question, if the drugs we're using are so good that we do not have any nodal disease evident after neoadjuvant chemotherapy, is any further treatment needed, the British trial? Or if you're going to give any other treatment, is radiotherapy perhaps needed, or just surgery? Or are they equivalent in the axilla? Now, one of the things I've focused on has been neoadjuvant chemotherapy. We are all, I hope, keeping safe and well and looking after our patients as best we can in these very strange COVID-19 times. But one of the things that has maybe forced many of us to revisit is the use of neoadjuvant endocrine therapy rather than neoadjuvant chemotherapy. The difference between neoadjuvant endocrine therapy and chemotherapy is that it's pretty rare for nodes that were proven positive before starting the neoadjuvant endocrine therapy to become negative with no residual disease. I don't think people have really adequately investigated how long we should give the neoadjuvant endocrine therapy for to try and get to the end-naught disease. I don't know whether it's possible to use the targeted axillary dissection approach. I'm planning to do this for the first time in a week on a patient who's very well educated, very well informed, and is very fearful of an axillary lymph node dissection, and has asked me to practice this targeted axillary dissection approach. I worry and I sense that her single node will still be positive, and I will end up doing a lower axillary lymph node dissection, but it's going to be interesting to see. The other thing that's going to emerge in the literature, I think in about the next 3 to 6 months, is the finding that even if you do have a little bit of residual nodal disease after neoadjuvant endocrine therapy, it doesn't have the same impact. It doesn't have the same poor survival connotations that nodal residual disease does after chemotherapy. And maybe that's because patients that have had endocrine therapy in the neoadjuvant setting often go on to have at least 5 and probably 10 years of adjuvant endocrine therapy. And then there's all these clever tests that who knows whether they're actually going to be useful in this setting. So coming back to a slide that you've actually seen most of this already, What do I try and do with my patients, certainly after neoadjuvant chemotherapy? Well, I'm hoping that Tamara and her colleagues have put a clip in the tumor and a clip in the node if the node was positive to start with. I'm keen the patient drives sensible choices between breast conservation, mastectomy, and reconstruction. For those who are originally node negative, I do feel that sentinel lymph node biopsy, we can argue which technique is going to be best, is the right thing to do. How many nodes should we be retrieving? Is it 3? Should we always be using the blue dye and technetium dual approach? For those patients who were originally axillary node positive, then if Tamara or her colleagues do an ultrasound, if clinically it seems that the lymph nodes have responded very well, then I'm an enthusiast for this targeted axillary lymph node dissection. And if there are still positive nodes, then either an axillary lymph node dissection or radiotherapy, I think, are both options. If there's been a very poor response clinically or on ultrasound, or if there are more than 4 lymph nodes involved originally, I'm afraid I still tend to go for an axillary lymph node dissection. And so I wanted to just shout out, as they say in the United States, for my colleagues in imaging. Tamara's chairing this session for a very good reason. My colleagues in pathology, without whom I could not be doing a lot of what we do. And at that point, I think it's going to be about time to open up to critique of what I've been saying, for us to try to address any questions, and maybe from the panelists to get some answers. With that, I'd like to say gracias. Thank you for listening to me for the last 20 minutes or so. And I hope we're going to have a great discussion just now. Thank you very much.
Thank you so much, Dr. Thompson. That was a fantastic presentation, and I'm sure that it's going to generate a very lively discussion. Really, really appreciate it. We will proceed now with our virtual roundtable with questions and observations from our panelists. Let's begin now with Dr. Nereida Esparza from Mexico. Dr. Nereida Esparza, you submitted a few of your questions in advance, so I'm going to go ahead and read some of them. First question is, it's clear that today's standard of care is sentinel lymph node biopsy in patients with negative lymph nodes that are ultimately confirmed negative. But what about the scenario in which there is not a conversion from node positive to node negative, knowing the false negative rate, which approach do you consider to be the best to evaluate response to neoadjuvant chemotherapy in the regional nodal basins, Dr. Thompson?
So I think that's where the multidisciplinary approach is important, Narita, that I like the fact that I work with Tamara and her colleagues who are exceptional imaging radiologists and can do an ultrasound. So if up front, it's been obvious that there's 1 or more nodes that are involved, maybe the amount of cortex is 3, 4, 5 millimeters, and they've biopsied that and proven that, then I feel unless I can find that particular node and identify it, I can't prove that the patient has converted from node positive to node negative. And so I think as surgeons, we then feel obliged to do an axillary lymph node dissection.
Thank you, Dr. Thompson. Another question was, when we say positive lymph nodes that convert to negative lymph nodes after neoadjuvant chemotherapy, and we consider that N1 disease, is there a possibility of doing a sentinel lymph node biopsy in cases in which there is evidence of complete response in N2 disease, knowing the low number of these cases, the low number of cases that are included in the studies?
I wish I was brave enough to do that. And I say that because I think we have all seen now with the anti-HER2 therapies, with some patients with triple negative breast cancer, that the most astonishing responses can occur. But I'm afraid I have not been brave enough to offer to patients who present initially with N2 disease such small surgery, sentinel lymph node biopsy. I would still, I'm afraid, counsel the patient that axillary lymph node dissection is what I would tend to do, but I'm happy to be criticized and hear other viewpoints.
Thank you, Dr. Thompson. Last question. A positive sentinel lymph node after neoadjuvant chemotherapy, aside from the resistance to the same chemotherapy, it would indicate the need for additional axillary therapy. Are we ready to select or choose cases in which not doing an axillary lymph node dissection is an option? For example, in cases where there is a low tumor burden?
Yeah, that's a fantastic question. And I think that the trials that I was mentioning, particularly the United States trials, are going to start to answer that question. Personally, I usually discuss with my medical oncology colleagues, and particularly with pathology, if they found some isolated tumor cells or micro mets, then perhaps I'm happier with the lesser morbidity of radiation therapy. If, however, that patient still has 1, 2, 3, 4 macromets or extranodal extension, I think many of my medical oncology colleagues, wisely or unwisely, trust that a surgical clearance, maybe with radiation on therapy on top of that, will be the best bet for the patient to become disease-free long-term. So the burden of disease in the axilla, what the pathologist can find, I feel directs surgical or radiation therapy or a combination of the two. And of course, it also tends to, in the days of HER2 therapy and the Catherine trial results, if we have drugs expensive and hard to come by as they are, like TDM1, we may want to continue anti-HER2 therapy afterwards, or in triple negative breast cancer, we may want to continue with capecitabine afterwards if there is residual disease.
Thank you, Dr. Thompson. Dr. Lubera or Dr. Leon, any questions or observations regarding these three questions, wonderful questions that Dr. Esparza submitted?
Yeah, it's a pleasure for me to be with you, especially with Professor Thompson and my colleagues from Ecuador and Mexico. I want to make a question, because in Peru, we use only in Lima, in the capital, we use only the mixed technique, use blue dye and technetium. But in the rest of Peru, the other cities, we have we don't have the technetium. So we only use the blue dye. I heard that this technique, new technique, the max seed, and I had the opportunity 6 months ago visit Dr. Thompson in Baylor, and I see the technique. What do you think about to get that technique, novel technique here in South America, Dr. Thompson? They use the max seed.
Yeah, it's a great question, and there are two components to this. The first is that the mag seed is a little metal seed that in the trials that have been done is as good as an iodine 125 seed in terms of finding either a single lymph node or an impalpable cancer. Separate to that, but using the same probe, the same guidance system, there is the MagTrace dye. Now, I went over that very briefly, but the MagTrace dye originally was used as an MRI contrast dye. It's been adapted so that the size of the particles, the ferrous oxide covered in dextran, is 60 nanometers. So what I do, as you saw, is I will inject it under the areola, and within 20 minutes, it has gone to the sentinel nodes. It has been trapped in the sentinel nodes. And because of its size, it travels quickly and gets stuck there. And in the studies that have been done, not after neoadjuvant chemotherapy, I agree, but in the primary setting, the head-to-head comparison between MagTrace, this dye injected at the time of surgery, versus blue dye plus technetium, head-to-head, it is non-inferior. So they're very, 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 very similar to each other. The difference, and the reason I have changed over to MagTrace in much of my practice, is that for me in the United States, the cost of the MagTrace is 1/6, a fraction, much, much less than the cost of the technetium and the blue dye. And I use in answer to one of the questions that's been raised, the isosulfan blue dye rather than the patent dye. So in answer to your question, I would love to see this single injectable on the table with the patient asleep mag trace available in Peru, not purely in Lima, because I think you have many facilities in Lima, but in places where there isn't the opportunity to use radiolabel, I think it would be a very good option. Thank you for asking that question.
Right. Thank you, Professor Thompson.
Yes.
Yes.
Can I talk? Well,
Yes, Dr. Esparza, thank you.
Thank you, Dr. Thompson, for the great lecture. So quickly, in Mexico, specifically at NCI, we try to use the same indications that Dr. Thompson has shown from the use of sentinel lymph node biopsy, the dual technique, or the search for 3 lymph nodes. But at the same time, Dr. León said that his country is so different, so Mexico is always so different in different regions. So our biggest difference is perhaps in the use, maybe in some tools or some devices. For example, we don't have MAC seeds or radioactive seeds, but the rest of the country don't have blue dye. It's so difficult to us to talk about a standard to treatment or to choice to all the surgery in the rest of the country. But to exemplify, I like to show or to talk in a survey that I carry out on Mexico surgeon. Only 60% answered that they always do sentinel lymph node biopsy after neoadjuvant treatment. So perhaps the results from the Z0011 changed paradigms, but there are still reports for the low practice in everywhere. Look the reports from Monica Morrow.
Yeah, so I think one of the difficult things we all face is that different countries, and within different countries, different regions may have access to technologies which are not the same. And I come from Scotland originally and used to work in a very remote hospital which had no radiation facilities. And we would have to use blue dye, and we had nothing else. And even with that, we were able to do a node sample directed by blue dye, which seemed to be quite effective. So almost everybody who will be doing this surgery will be a talented, well-trained, excellent surgeon. And if by using the blue dye alone, he or she feels that she can find 3 sentinel nodes with the blue dye, and Dr. Morrow in New York says she can do it. So if she can do it, maybe some other people can do it. I would like to think that we have such integrity as surgeons that if just using a blue dye, we can find 3 lymph nodes, and that will be adequate assessment for the axilla, then in the circumstances that we have to practice, let's go with what we can do and not wish for things that are not possible for us. Yeah?
Okay. Thank you.
Dr. Lupera.
That's my question. You know, after neoadjuvant systemic therapy for the patients with lymph nodes positive before surgery, before chemotherapy, when do you find lymph nodes positive after surgery? The standard of care is to complete with the radiotherapy to the supraclavicular nodes and also to the mammalian internal nodes.
Yeah.
Do you make routinely radiotherapy to the axilla? I know that the studies are just in course, but what do you do routinely?
Yeah, so that is a fantastic question. I am not a radiotherapy doctor, And each place I have worked, and I've worked in 3 different places in the last 6-7 years, I have gone to knock on the door of the radiotherapy team and to discuss with them what their expectations are. So they will give now internal mammary chain, they will give supraclavicular radiotherapy. In the axilla, I will try and take the level 1 nodes. If Tamara and colleagues have said only level 1 are involved, that is what I will take. If they have originally said level 1 and level 2 are involved, that is what I will take. And I will inform, I will discuss, I will let the radiation oncologist know that what surgery I have done so that they can fine-tune their radiation delivery. What I try to do is not to remove the level 3 nodes because of the evidence that removing levels 1, 2, and 3 seems to have no difference on outcomes, but can make much worse the lymphedema. And then if patients do develop lymphedema, and forgive me, my patients have developed lymphedema, and I think all of us as surgeons experience that, then I try and make sure that with the ways of dealing with lymphedema, we try to reduce the impact of that lymphedema. And there are some surgeons, usually in centers of excellence, Mexico City, in Quito, in Lima, as in Houston, who are very talented at doing microsurgery to try to establish lymphatic channels to deal with the lymphedema. It is not something that I have ever invested time in, but I think there are some plastic surgeons who are very good that way. So in answer to your question, I talk to the radiation therapists. I try and make sure that before I do the surgery, I'm thinking based on the imaging beforehand, what am I going to do? I make a very meticulous record of what I have done. I mark where I have done the surgery with Liga clips, with little metal clips. And then I discuss again with the patient and with the radiation oncologist afterwards, what are we going to do? And if lymphedema occurs, then I try to make sure we manage the lymphedema, and I try to help that patient with a surgeon, not me, who can also do some lymphovascular surgery.
Okay. I have a second question.
Thank you.
Which patients definitively you exclude from neoadjuvant chemotherapy?
Yeah, so this is a very tricky question. So you have seen on my slides that I think it is the biology that is most important. And so for me, a HER2 positive cancer or a triple negative breast cancer of any size, I will discuss with my friends and colleagues who are medical oncologists, Matthew Ellis, who we heard from 2 weeks ago, Kent Osborne, and others. Sometimes they will say for a 1 centimeter or less triple negative breast cancer, for a 1 centimeter or less HER2 positive breast cancer, they will say, Alistair, go and do your surgery, particularly if the patient wants breast conservation, particularly if she is node negative on Tamara or her colleague's examination. For ER positive disease, I think it's much more difficult, but for triple negative or HER2 positive disease of 1 centimeter or more, I'm often asking for neoadjuvant chemotherapy for those patients. And then there are the patient's circumstances. We sometimes see patients who come from a long way away or don't have the resources to have the chemotherapy. And for those patients, we may do surgery first.
Okay.
Thank you.
Thank you, Dr. Rivera, for your wonderful questions. I have received quite a few questions from the audience, so I would like to go ahead and get an opportunity to ask them and see what all the panelists, our speaker, as well as all of our panelists have to weigh in, have to say about it. First question I received was, you said whatever blue dye you use, is that isosulfan blue and pan blue, or do you believe metalin blue or others are okay?
So I think it matters more that you use the blue dye wisely than which blue dye you use. Recently, I had used isosulfan blue that can cause problems with anaphylaxis. So we used to be very careful of the sulfur allergy that can spark. I have used methylene blue in the past. I have used patent blue in the past. I think whichever blue dye you have available is good to use, but just be aware they all carry their potential problems.
Thank you. I have another question. Do you believe personally that blue dye alone or technetium alone is as good as blue dye plus technetium?
Somebody is being very cruel to me, putting me on the spot. My personal view, and this is based on the evidence that as I read it, is that the two together, the blue dye plus the technetium, gives you the best chance of doing a good sentinel lymph node biopsy. And as I was saying earlier, that there are times where I did not have the technetium, so I simply had to use the blue dye alone. I think it would be unusual, but sometimes people will only use the technetium. And I had one patient who was very allergic to sulfurs that I did not use the isosulfan blue, and we found two very good lymph nodes with the technetium and the third clip node. So you have to adapt to the circumstances, but I believe personally that using two, not one, is right.
All right, I have another great question from the audience. Could you tell us more about your experience with the magnetic marker? It's not specified if the question is regarding MagSeed or MagTrace, so I decided to ask you regarding your experience about both.
Yeah, so with the MagSeed, I found that the little seed, which is tiny, it uses the same needle that a 14 gauge core needle for doing cores would use. I found it's quite comfortable for the patients to have this placed. Tamara, is that your experience too?
It's very, in terms of the gauge of the, yeah, it's very similar. I would say it just with what small skin nick, just like we use for your core needle biopsies, we're able to get it no problem. It depends on which, if we're using MagSeed, I would say it's very, very similar. If you're using Savvy Scout, perhaps it would require a slightly bigger nick, but yeah, they're very, very similar. And the insertion technique is exactly pretty much the same as you would do when you are inserting a biopsy clip. So it's very intuitive for us.
Yeah, so the MagSeed is very easy to put in. It stays in the same place that Tamara or her colleagues have placed it. We can place this not on the morning of surgery the way we have had to do with wires, but we can place it days before. And there are studies which are saying you may be able to place this months before. So I think it's very easy to place, stays in the right place. To detect it at the time of surgery, I have found no difficulties. There is the issue that when you have metal instruments next door, that sets off the probe. So you have to be a little bit thoughtful, but you get used to that very quickly. And I found it as good in my hands anyway as the iodine seed, as good as the Savvy. And my preference is for the MagSeed over the guide wire, because I can then time the surgery for whenever it suits rather than have to have the wire put in on the morning of surgery. So that's the seed. For the MagTrace, for the dye that I am injecting on the table under general anesthetic, as I was saying to Mauricio, I found that just as easy to use in terms of detecting sentinel nodes as the 2-dye technique. And although, again, you have to be a little bit careful with metal instruments, you have to be just a little bit wary that there's, you find and can detect that tracer. You can see the little brown dye. Sometimes you can certainly pick it up with the probe. I found it as straightforward as the blue dye and the technetium can be. So I hope that gives you a little example of the thinking behind changing to these techniques.
Thank you, Dr. Thompson. Dr. Esparza, did you have a comment?
I have a comment. I think in the life of surgeons, we have a moment. And I believe that the surgical technique or surgical skills is more important than a tracer or a blue dye or different colorants, no? So we can talk all the day about different kind of devices or techniques, but it's more important the hand.
Yeah, I completely agree with you that whatever technique we are using, a well-trained breast surgeon can probably use any of these techniques, but it is this, and is it the hand and the coordination in your hands. It will work beautifully, whatever technique you use. And we should be ensuring that those we train are as good, if not better than we are to do these techniques.
Thank you.
I have another question for
A
Dr.
question.
Dr. Leon, you had a commentary or a question?
Yeah, commentary and a question. In Peru,
Go ahead.
we have three-piece PET CT, 2 in a public and 1 in a private, and soon will be one more in a public. So in the future, we have more PET CT. Professor Thompson, what do you think about the utility of the PET CT in the assessment of the axilla?
So I think PET CT is very good if there are nodes with enough tumor in to light up the PET CT. But the problem that all of us face is where there is very subtle amounts of tumor, and particularly after neoadjuvant therapy, the PET CT may be switched off because the tumor is not metabolically active, but there may still be plenty of tumor in that lymph node. So as Narita was saying, I think it is important that surgeons are trained, and that, as you say, Mauricio, we are mindful that the technology can be very clever, but it may not be as smart as we need it to be.
Yeah, thank you.
We have another great question from the audience. Dr. Thompson, what do you think regarding RFID traces as soon as they're more accessible? I guess this is a question, it's the technology is not accessible currently, but what if when it becomes accessible, what are your thoughts?
I think that comes back to the fact that there are many techniques, and it is about, as Narita was saying, having the surgeon able to use whichever technique is available. And the RFID tracers, if that is what you have available and you're comfortable with it and you can do a good service for your patient, yes, absolutely, make use of it.
Thank you, Dr. Thompson. Have another question. Starts out by saying, thank you for your answer on isosulfan versus patent blue. I believe the molecules are very similar. I know this is not the point of your lecture, but I would like to ask, have you heard of methylene blue for sentinel lymph node biopsy? I would say.
Yes. So people have used all sorts of blue dyes, and I guess whatever you have available, people will use methylene blue. There is a problem that I have seen, but not personally encountered, which is of skin necrosis with methylene blue. So it's something that you need to be a little bit careful about. But if the only blue dye you have is methylene blue, then it can be made to work very well for sentinel lymph node biopsy. Thank you for your question.
I would like to make a commentary. I see that we have Dr. Hadi Mohammed Abu Rashid from Qatar. We know it's 3 a.m. over there, so we would like to thank you for joining us. I have another question from the audience. The scenario of the current pandemic is confronting us with questions about how to treat early luminal cancer that are less than T2 and 0 with neoadjuvant hormonal therapy. In this case, at the time of breast surgery and sentinel lymph node biopsy, would you consider applying the Z11 criteria, given that these patients have to be operated on at the beginning?
Yeah, so I think one needs to be a little bit careful that the Z11 criteria were not after neoadjuvant therapy. So we're extending and thinking about things in a little bit of a different way. If your patient is T1, T2, N0, and you've put them on endocrine therapy, then I would suggest that doing whatever breast surgery you're planning, plus a sentinel lymph node biopsy, is probably still going to be doing a good service for your patient. And I see some nodding heads on the screen. So I think we'd probably all be in agreement that we are trying to first do no harm, but also to do the right thing for our patients. So thank you, Dr. Rabaza.
All right, I have one more question here. Have you evaluated the patient's ability to understand those complex steps of decision-making?
I haven't, and I think there is room to examine further just how much patients understand about the whole pathway of care. But around the time of surgery, I think we try to explain, but it's complicated. I still find it complicated. And I think what's behind your question is that often our patients invest their faith, invest their belief that we are trying to do the best thing we possibly can for them without fully understanding exactly what is going to be done. Great question.
Got one more question here. How about axillary reverse mapping?
So axillary reverse mapping is where we're trying to map out what are the lymphatic channels. There is a study which I am trying to join, I will join, and my colleagues at Baylor will join, which is run by the Alliance for Clinical Trials. And Suzanne Klimberg is the person who is leading that trial. And it is to aim to demonstrate the value, the long-term value of axillary lymph node mapping. The aim being to only take lymph nodes which serve the breast and to leave behind the channels and the nodes that serve the upper limb. So I think it's a great idea. I think it's being tested. And I hope we at Baylor, my two colleagues and I, will be joining that Alliance trial very shortly.
I would like to encourage the audience, if there are any other questions. I know that we're a little bit over 6 p.m., but we had so many wonderful questions. So we wanted to make sure that Dr. Thompson and all the wonderful panelists had an opportunity to listen to those questions and answer them and provide their opinions and their observations. If there are any additional questions, I would like to ask you to submit them by chat. Any additional commentary, Dr. Esparza or Dr. Leon or Dr. Lupera?
No comments.
Only thanks all Baylor's team for this opportunity. Thanks, Dr. Thompson, for sharing with us this great lecture again. And maybe the conclusion of this is use your better tool and use when you can use it, no?
Do the best you possibly can with the tools that you have. I agree. Yeah, thank you, Narita. I appreciate that. You've summed up what it took me 25 minutes to say in a short sentence. Thank you. Thank
All
you.
right. Well, I don't seem to have any new questions from the audience at this time. I would like to very much thank Dr. Thompson for his wonderful lecture and question and answer session. I would like to thank our panelists, Dr. Esparza, Dr. Leon, and Dr. Lupera for their wonderful insight, commentary. This has been a great experience. I'm very, very honored to be sharing this virtual roundtable with y'all. And thank you so much for everybody that's joining us. Thank you so much for your participation, for your great questions. And I'm looking forward to the next session on June the 10th. Thank you, everybody.
Thank you. Stay safe and be well.